Welcome, everybody. I want to personally welcome you to this episode of Brains with Brian. And this is a monthly series where we'll be talking to world experts in the field of neurology, research, rehabilitation, and music, and discussing all things from neurology and music and neuroscience, digital therapeutics. Each month, we feature a new expert who provide valuable insight into these important topics. This show is hosted by me, Brian Harris, the co-founder and CEO of MedRhythms, a digital therapeutics company focusing at the intersection of neuroscience, technology, and music to build interventions that transform the lives of those living with neurologic disease and injury. If you'd like to learn more about MedRhythms, please visit our website at www.medrhythms.com. I hope that you'll find today's episode interesting, meaningful, and compelling, and I believe that you will. And it's my honor to introduce our esteemed guest today, Dr. Bas Bloem. And Professor Bas Bloem is a consultant neurologist at the Department of Neurology at Radboud University Medical Center in the Netherlands. Professor Bloem is an editorial director on several national and international journals and has published over 800 publications, including more than 675 peer-reviewed international papers. His H-index is 103, according to Google Scholar. Professor Bloem is a past president of the International Society for Gait and Postural Research and recently became an officer for the International Parkinson and Movement Disorder Society. Since 2017, he has served on the Executive Scientific Advisory Board of the Michael J. Fox Foundation for Parkinson's Research. In 2020, he became co-editor in chief of the Journal of Parkinson's Disease. Professor Bloem founded and became director of Radboud MC Center for Expertise in Parkinson's and Movement Disorders, which was recognized from 2005 onwards as a Center for Excellence in Parkinson's Disease. He also co-developed ParkinsonNet, an innovative healthcare concept that now consists of 70 professional networks of Parkinson's disease patients, covering all of the Netherlands. Professor Bloem has two main research areas: cerebral compensatory mechanisms, especially in the field of gait and balance, and healthcare innovation, aiming to develop and scientifically evaluate patient-centered collaborative care. We are also honored to have Dr. Bloem on our scientific advisory board at MedRhythms. Bas, thank you for being here today. We're honored to have you, especially honored to have you during this month as being Parkinson's Disease Awareness Month. So thanks for being here today.
Wonderful. It's my great pleasure. Thanks for the invitation.
Well, just to get started, Bas, we'd love to start by asking you more about your personal background and why you chose to become a neurologist and specialize in movement disorders.
Well, it's partially good luck, I suppose, and partially it wasn't. My mother had multiple sclerosis, and she got married in a wheelchair. I was actually a forbidden child because she was under immunosuppressive treatment when she became pregnant. And I've always felt as a very welcome child and felt impelled to cure my mother. So I opted for a career not just in medicine, but I really wanted to become a neurologist. My first steps in research was in neuroimmunology. But in order to boost my career and enhance the likelihood of being accepted into a residency, I asked my boss if I could go to the United States. And lo and behold, in that very week, Bill Langston, which people may know as the guy who discovered MPTP Parkinsonism in California in the 80s, happened to be in Leiden, where I was trained as a medical student. So my professor introduced me to Bill, and I said, "Are you studying MS?" He said, "No, it's Parkinson's." I said, "That's no good." But he says, "I work in California." I said, okay, I'll do the dirty work. I packed my bags, traveled to California, and the rest is history, because from the moment I met people with Parkinson's, I forgot about MS, got really hooked on the disease, which is fascinating. But in particular, I continue to be impressed and motivated by the resilience of people and how they deal with this horrible disease.
Well, thank you for that background, Bas, and would be great to hear more of your perspective on Parkinson's disease. You said you continue to be intrigued by this, and could you talk a bit about what Parkinson's disease is? Perhaps your thoughts on what causes Parkinson's disease and generally how it impacts patients.
Well, to begin with, I don't think there is such a thing as a Parkinson's disease. I think it is more appropriate to speak of Parkinson's diseases. We know that there are a number of genes that by themselves are sufficient reason to develop what we call on the outside Parkinson's disease. Parkinson's disease is defined clinically as the combination of a particular set of symptoms It requires bradykinesia, the slowness, plus at least one other motor symptom, asymmetric, slowly progressive, etc. But that syndrome, which is really a syndrome, can be caused by genes. But one thing that I'm increasingly worried about, and that I've published quite a bit about, is the role of toxic chemicals in our environment. Parkinson's disease was distinctly rare prior to 1817, when James Parkinson described the disease. When he found the disease in London, the Industrial Revolution was ongoing. We now know from a number of studies that air pollution is one of the contributing factors to Parkinson's. We're particularly concerned about pesticides used in agriculture. Farmers have a markedly increased risk. Other toxic compounds like trichloroethylene, a solvent used in industry, is a likely cause of Parkinson's. Repeated head trauma, brain concussions, even headers in football, in soccer, as we say in Europe, is a risk factor. And what is really fascinating is that the genes interact with the environment. So if you have a certain genetic predisposition and you're exposed to pesticides or trichloroethylene, then the double hit is more likely to explain your Parkinson's. So there isn't just one disease, there are multiple factors that contribute. And may I quickly say there are also protective factors, which makes it even more fascinating. Regular exercise, I'm very passionate about exercise. I'm a former athlete. We can maybe talk about that later. But exercise protects against Parkinson's. So does a Mediterranean diet and a few cups of coffee. Smoking, oddly enough, is inversely related to the risk of Parkinson's. Nobody listening to this discussion today should start smoking, because the risks of smoking clearly outweigh any advantages. But it just tells you what a complex interplay ultimately explains whether or not you develop Parkinson's or not.
Yeah, it's fascinating. And actually, I have here, this, which is the book that you wrote.
Right. Oh, wonderful, wonderful.
On ending Parkinson's disease, which is actually dives deep into this very topic, which I found to be fascinating and really making us think about the choices we make, not only as individuals for our own lives, but that we make as society, and how these can really drastically impact the world that we live in.
Yeah, no, it's nice of you to mention, but can I just quickly say that all proceeds of the book go to the greater good, research into Parkinson's disease. You can order it on Amazon or on endingpd.com. And the reviews have been really positive. People seem to enjoy reading the book. So I hope people will be motivated.
Well, I can tell you firsthand, yes, it's a fantastic book. So thank you for that. And thank you for being a part of writing that and putting that out there. So can you talked a little bit about bradykinesia and these types of things. Can you talk a bit more? How does PD or Parkinsonism present themselves? What does it look like to have?
So it's a disease that people mostly know about because of its motor symptoms, because these tend to be very visible. It's the slowness of movement, stiffness, a tremor, although a tremor is not synonymous to Parkinson's. About 1/3 of patients never develops a tremor. Changes in posture, in gait, in balance. These are the motor features, but we increasingly realize that this is only just the tip of the iceberg. The same Bill Langston, my former mentor, published this beautiful paper in the Annals of Neurology with an iceberg, where, as you know, 10% is above the surface, 90% is below the water surface, and that 90% is depression, constipation, sleep disorders, sexual issues, pain, urinary incontinence. I mean, it is it's a complex and thereby devastating disease. And these invisible symptoms, as people with Parkinson's tend to call it themselves, contribute most to the quality of life.
Yeah, thank you for digging into that now. And what sort of research are you working on now? What's the latest and greatest at the moment?
Well, what am I not doing?
That might be an easier answer, huh?
My group is growing like a Dutch cabbage, as we say. I currently supervise close to 40 PhD students, which is way too many. It's a lot. But if you look at the types of research that we're doing, part of it is into to build an evidence base for allied health interventions and for integrated multidisciplinary care. So we're doing trials of speech and language therapy, trials of occupational therapy, trials of physiotherapy. We're doing lots of work into exercise as a symptomatic treatment, but also as a possible disease-modifying treatment. We're doing a lot of research into patient-centeredness, how to involve people living with the disease in a process of co-creation as equal partners, both in care and in science. And that's a topic that's very, very close to my heart. We're testing novel non-pharmacological interventions. One really cool study that we're now doing is we're testing the effects of hypoxia, intermittent hypoxia, bringing people to 4,000 meters altitude for just 5 minutes as a novel way of squeezing out dopamine in the brain, but possibly also promoting adaptive neuroplasticity as a disease-modifying treatment. We're doing new treatments for orthostatic hypotension. And then I've got a big group on wearable sensors, remote measurements, supported by machine learning and artificial intelligence. And of course, historically, and this is how you and I know each other, we've done a lot of work on gait and balance, posture and stability, which is one of the most debilitating features of Parkinson's. And my latest grant, and I didn't know you were also that much into music, is about art in Parkinson's. So we just received a 1 million euro donation by the Austrian government to now study art, personalized art, as a novel therapy for people with Parkinson's, which I find the coolest thing. So it's a broad portfolio, but it's all boiling down to, ways to improve quality of life for people with Parkinson's.
Yeah, very broad approach to research there. Fascinating. I mean, that must also be some of the fun and excitement of your role as well, to be able to be a part of the many different aspects of research and topics of research that are going on in the field.
Exactly. So my Wednesday is my research day. So I always call it door open, closed door day, because all my researchers come in for 20 to 30 minutes to discuss their findings, and it goes from left to right and front to back. But it's so gratifying to be able to have such a broad portfolio. And I'm just surrounded by the most brilliant young researchers. We have a very good way of identifying top talents, and my team is now attractive also for attracting, the elite young people. And they're way more clever than I am. I always have myself surprised. I feel like the grandfather of the group, but they are way more brilliant than I ever am. And so it's just a pleasure to work with these young talents.
Yes. Yes. And one of the things that I've always found very compelling about your work, and actually it's written in one of your bios, about how you value publications on remarkable observations in single patients. And I think as we think about researchers doing, and we always think about proof and needing more evidence and larger sample sizes and, longitudinal studies, in your perspective, why are one patient single case observations important?
So, they are particularly important. So what people often say is, oh, a case report is no evidence, but that's not true. A case report is definitely evidence, although it's not penultimate evidence. But for that individual, it is the best possible evidence you can get. If you have evidence from a randomized trial in 100 patients, it means that some people improved, others maybe didn't, and others stayed the same. So if you now take the evidence of a trial to an individual, there's no way you can guarantee that he or she will respond. So as an example, in this hypoxia study, we're now using a multiple N of 1 design where each patient receives their own personalized treatment protocol intermixed with occasional placebo interventions to find their personalized regime of hypoxia. And the added sum is not an average treatment, one size fits all, but it's personalized. So it's personalized medicine, that's one. It's a source of inspiration and motivation. So you may recall this very famous patient that I described in the New England Journal of Medicine who was unable to walk but still ride a bicycle. That launched a whole series of further studies that led us to understand how freezing of gait develops. What is the pathophysiology? If you can cycle, what does it tell you about the mechanisms underlying freezing of gait? Plus, we now have 5-6 studies using cycling as a new therapeutic intervention, as a way for rehabilitation in Parkinson's. It all starts with N of 1 observations. And clearly, it's not the end of the world, but the sum of multiple N of 1 observations or an N of 1 observation followed by a trial is the way forward. And I really enjoy, looking at these individual observations.
Well, thank you. I think that's a really important perspective for us all to hear. So I appreciate you sharing that with us. I'd like to go back to something you mentioned as you're talking about your research and dig in a little bit about exercise in Parkinson's disease. And both you mentioned as symptom management, but also potentially as disease modifying impacts. Can you talk about your hypotheses there? What could be underlying that?
So, well, we can brainstorm. In many ways, exercise is still a black box. So you know what goes in. That's a workout, maybe 45 minutes at 80% cardiac output. And what goes out is symptomatic improvement or sometimes fatigue. And I will tell you in a minute about some imaging studies that we've performed. But how that is mediated in the brain, people have speculated about release of growth factors, change in perfusion of the brain, and other types of and changes in functional connectivity in the brain. But what exactly drives the plasticity, we don't know. What I can tell people is we published a paper this week. So Brian, you have the debut here. We published a very cool. But it was an editorial based on findings by another group, in all fairness. But people studied a model of Alzheimer's in rodents. And this is just too cool to be true, but they had exercising rodents and non-exercising rodents. And the exercising rodents did better and had brain plasticity. When they transferred the blood of the exercising rodents to the lazy rodents, they also enjoyed the benefits of exercise. So I hope that people at home don't think, oh, I'll sell my treadmill and I'll call for a blood transfusion. I'll let my neighbor do the running. But it means there's something in your blood, in answer to your question. And they identified the active ingredient as a chemical called clusterin, which is involved in anti-inflammatory processes in the brain. And we speculate in our editorial, which came out this week in Journal of Parkinson's Disease, that perhaps clusterin is also the mediating factor that drives the beneficial effects of exercise in Parkinson patients.
It's fascinating, particularly around this area of exercise. There's a lot of new research across the board and benefits of exercise. And a couple of months ago, we had Dr. Kirk Erickson on this show, and we talked about, he's at the University of Pittsburgh, and a lot of his research is on the correlation between exercise and cognition, and specifically looking at hippocampal volume, and actually looking at neuroplastic change driven by exercise. And I think the more that we understand this, it becomes very compelling as we think about it as a treatment, if we can figure out a way to do it in a, as you say, more of an individualized, customized way for each patient.
Yeah, absolutely. Yeah. So just to share with the folks at home listening, I think one of the most provocative papers that I ever published out of that large volume that you quoted, and in fact the numbers are even higher today than they were, is a study where we put stationary bicycles into the people's homes, because we felt that having to go to the gym all the time was a barrier. So people received a stationary bicycle in their home and were asked to do a workout lasting for 30 to 45 minutes, 3 times a week at 80% of maximum cardiac output. And we gamified the entire intervention with a specialized app that motivated people to start with the exercise, that rewarded them during the exercise, and offered further rewards after the exercise. Compliance was brilliant, and the results, published in the Lancet Neurology, an elite journal, showed that while the control group, which did only stretching exercises, declined over time, which is what you expect in Parkinson's, the intervention group stabilized their motor symptoms, which I found really compelling. But to make it even more interesting, in a subgroup, we did functional and structural brain scans before and after the exercise and before and after the stretching. And lo and behold, there was some atrophy, shrinking of the brain happening in the stretching group that was stopped from happening in the exercise group. And even more importantly, the exercise group made new functional connectivity between the diseased basal ganglia and the cortex. I mean, how cool is this? We knew that this was happening in rodents. First time ever, we've shown this in human beings, published in the Annals of Neurology. And literally every time in my clinic, I sit in front of my patient and I tell them, if you're on your treadmill, if you're on your stationary bicycle or whatever, it doesn't matter what you do, as long as you do something, and you're sometimes not motivated, think of the new connections that your brain is making while you're exercising. So, there's no ifs, ands, or buts. People should exercise.
It's fascinating. It's fascinating. Well, that study that you just mentioned, how long was the intervention period from the pre?
Yeah, that's a good question. It was only 6 months. So that is good and bad. I mean, the good news is, even after 6 months, you see a tangible effect on your clinical symptoms and a tangible effect on the quality of your brain. I mean, that's amazing. The downside is, what is long-term compliance? People live with Parkinson's for 20, 30, 40 years, depending on how old you are by the time you develop the disease. So long-term compliance remains an issue, but perhaps the effects are even augmented if you exercise for prolonged periods of time. 6 months was the best we could do within the framework of the funding and the study. What we need now is long-term studies, 1, 2, 3, 4 years of intervention.
Yes. I mean, the researcher and the clinician in me get really excited about this type of data, and particularly thinking about the details as well. And in that particular study, how was exercise? Was it defined by a certain duration or heart rate, or how did we define what exercise was?
Yeah. They did a maximum heart rate test prior to the study for 2 reasons. One was for safety. And second, when we had their maximum heart rate, we could titrate their exercise towards their maximum heart rate. So the dose was 80% of their heart rate. But here comes something very interesting and important for all the folks listening. Cardiac innervation is also abnormal in many individuals with Parkinson's. And we have published work to show that some patients are unable to crank up their heart rate beyond a certain limit. So if you dose your exercise relative to your maximum heart rate, it could be frustrating because the people with Parkinson's, not all of them can crank up their heart rate sufficiently. So what I always tell my patients is the right dose is if you start to pant, but can still maintain a conversation. So you are doing your exercise, but your sentences become a bit more brief. That's the right dose.
Fantastic. Well, thank you for that. So big takeaway from today, no matter what, exercise, and exercise often.
You're right. And just quickly, because this is the most frequently asked question I get, do I need to buy myself a home trainer? No, it doesn't matter what you do, as long as you start to pant or crank up your heart rate a little bit. So whether it's a brisk walk, jogging, golfing, even gardening, or just regularly taking the stairs instead of an escalator. It doesn't matter what you do, as long as you adhere to it, and you can vary it to make it more palatable so that you keep up your exercise regime.
Fantastic. Thank you for that, Bas. Now, digging a little bit deeper here, wanted to talk a little bit more about Gait. Obviously, this is something that you've published extensively on, and specifically how Gait deficits lead to significant impacts in the lives of those living with PD. Can you talk a bit more about those Gait deficits, what they are, how they present themselves?
Yeah, so there's basically 2 types of Gait abnormalities. And by the way, there's a question by David in the chat He asked for the references. I can tell you, David, and he's enjoying the conversation, so that's nice to hear. So David will gladly share the not only the references, but if needed, I can send the PDFs to Brian so that he can share it with the folks. I mean, I'm not sure if it's officially allowed, but I don't care.
Well, thank you for that. And I will just say thank you for noticing that, Bas. Anybody that's watching that would like to ask a question, feel free to pop it in the Q&A section here.
Yeah. So there's two types of gait abnormalities. One is what we call the continuous gait abnormalities. It's the shuffling gait. And by continuous, I mean it's predictable and continuously present. So people are shuffling, but it keeps going at a constant pace, which is typically slow, more shuffling, stooped posture, reduced arm swing. That's obviously not nice to have, but it's at least something you can anticipate because it is continuous. There's a second type of gait abnormality, is what we call an episodic gait disorder, which is sometimes there and sometimes it isn't. This is called freezing of gait. So people walk normally and suddenly they're stuck. And this is the most debilitating part, because what people don't realize is that walking means throwing your center of mass forward and then quickly putting your feet underneath. So if your feet get stuck, people fall flat on their nose. And if you freeze during turning, people fall sideways onto their hip and they fracture their hip. So we now know that these episodic gait disturbances, most typically freezing of gait, where people feel as if the feet are suddenly being glued to the floor, are the most important reason for injuries and fractures in Parkinson's disease. Those are the two main types of gait abnormalities.
And we know that certainly once the falls and the fractures happen, that really leads to a cascading impact of really deteriorating health over time. And so anything that we can do to prevent those is going to be important. And obviously at MedRhythms, we're focused a lot on gait and also music and the impact of how rhythm can be used for across neurologic injury or disease. And specific to Parkinson's disease, can you talk a little bit about rhythmic auditory stimulation, some of the science around rhythmic entrainment that you're familiar with?
Sure. So the one thing that makes Parkinson's, and I'm going to use the word in the most cautious possible way, but a gratifying disease to treat, and I'm using it cautiously because there's nothing gratifying about Parkinson's, but for me as a physician and for physiotherapists and rehab specialists, Parkinson's is a gratifying disease because unlike stroke, where the motor, the engine in the brain is damaged, what is completely radically different in Parkinson's is your start engine is damaged, but the engine itself is still intact, which is the cortex. So if you can bypass the defective automatic pilot, if you will, people can still walk normally. Think of my patient who was unable to walk, but able to ride a bicycle. He was able to bypass the defective start engine for gait and still use his legs effectively. They were not paralyzed. And we now know that both the continuous gait abnormalities, but also the episodic gait abnormalities can be treated by bypassing the defective start engine using external stimuli. And these stimuli can be visual, for example, stepping over small obstacles. They can be auditory, for example, rhythmic beats or a rhythmic music. They can be mental, sort of internally counting 1, 2, 1, 2, 1, 2. And these strategies are highly effective. If you look at the different types of external stimuli, so there's three basically. It's visual, auditory, and tactile. Patients like the auditory stimuli best. The research is most robust in the field of auditory stimuli, and it clearly leads to improvements in gait.
And can you talk a little bit about, as it relates to what those improvements look like? You've talked about sort of the fascination, the freezing of gait. What does the research show about or demonstrate about the impacts of auditory cueing on those actual parameters?
It does a number of things. It improves gait velocity. It improves gait safety. It reduces gait variability, and gait variability is a marker of falls and disease severity. it reduces the number of freezing events, and thereby we suspect that such rhythmic stimulation will ultimately prevent falls from happening. I'm not aware of any studies showing convincing effects on hip fractures yet, but this is something that is likely to be expected.
Mm-hmm.
So gait quality improves, and more importantly, gait safety improves.
And as I recall from our previous conversations that we've had, Bas, you mentioned RAS or auditory cueing being included in the guidelines for PD care in the Netherlands. Is that correct?
That's absolutely correct. And you're using the technical term RAS, but rhythmic auditory stimulation, just for all the folks who may not be aware of, because you and I are so familiar with this terminology, but this is the metronome, for example, that I mentioned. But in fact, music in many ways is a rhythmic auditory stimulation.
And is this something that you find, or as a neurologist treating patients, that are you recommending that to patients? Are people using this with physical therapists? Like, how does this actually get implemented today?
So it gets implemented in two ways. So the interesting thing is there is no doubt it's efficacious. You know, it's part of guidelines, as you mentioned. It's part of international guidelines. No doubt rhythmic auditory stimulation is an effective treatment. Now, what I find so fascinating, and we talked about N of 1 observations, is this is another example of personalized medicine. So there are people who want nothing but rhythmic auditory stimulation. And there are other patients who may superficially look similar, who really want visual cues to improve their gait. And there are other people who swear that tactile cues are best. And there are a range of compensatory strategies. So the two things I want to emphasize here is we're living in an era of personalized medicine. I think patients with debilitating gait difficulties, or maybe even early gait difficulties, should be offered the opportunity to experience the benefits of auditory stimulation. Mm-hmm. I think many of them will opt for auditory stimulation, but some won't, which is fine, because we have a whole repertoire of other strategies to also bypass the defective basal ganglia. So this is truly personalized medicine. And another element that's not been well studied is that there's a suspicion, although it's never been proven, that maybe if you do, for example, rhythmic auditory stimulation or another type of stimulation for a long period of time, it may become automatized and lose its efficacy. That's never been shown. It's only sort of a theoretical concern, but that makes it all the more important to have a battery of interventions tailored to the individual at hand. And one other thing that I really wanted to emphasize is the importance of either a good company like yourself or a good therapist to find the good rhythm. So Alice Nieuwboer, a famous professor in Leuven and a wonderful scientist in this field, did beautiful work to show that if you don't pace a particular individual's gait right, so if you put the frequency too high, people start to festinate and you worsen the problem. Mm-hmm. So RAS is not a one size fits all. It's as you know, but I'm telling the folks at home, it's personalized. Find the right rhythm for your individual patient.
Right. And I think and I appreciate you saying that, Bas, and making that distinction of when we talk about using rhythm or music, even broadly as an intervention, we're not talking about turning on your Spotify playlist and listening to music while you walk. The idea of personalized medicine is both for that individual and what they need and what they want, but also the purposeful application of that rhythm, because otherwise it could in fact actually be dangerous, as you call out. And it makes it's intriguing as we think about the conversation today. If we think about rhythmic auditory stimulation as a way of bypassing this start engine that you talk about, and really driving automaticity of movement, if you could use that as an element to actually help people drive more exercise, to your first point, and could
exactly
go to like a sort of a best case scenario intervention for patients, which is really, I think, an intriguing concept.
Absolutely. Well, I couldn't agree more. I mean, we can talk endlessly about importance of exercise, but if you cannot walk, if you're grounded by freezing of gait, it becomes a frustrating element. And if you now combine, for example, rhythmic auditory stimulation to promote gait, but also restoring people's ability to engage in exercise, you're a double winner.
Right. No, it's fascinating to think about the future. And let's just with a couple more questions here, Bas, thinking more about future. In your opinion, as an expert in the field, what does the future of PD care look like?
Well, there's a number of developments, I suppose. One crucial development is towards Parkinson's with a drug alone is way behind us. So multidisciplinary care with involvement of up to 30 professional disciplines. We published a paper in The Lancet, which I'm also happy to share with the folks last year, an invited review paper with a beautiful cartoon showing 30 professional disciplines orbiting as planets around the patient who was depicted as the sun at the core of the universe. People think of physiotherapy and rehabilitation specialists, but it involves dentists, pulmonologists, gastroenterologists, psychologists. I mean, the list goes on and on. So multidisciplinary care. Second, personalized care. So get rid of the one size fits all and looking at individualized, personalized treatments, partially tailored to your DNA, but partially also tailored to your preferences and personal wishes and needs. Active patient involvement and engagement as partners in care, as partners in science in a process of co-creation, I think is a crucial development. I think we will be seeing a move towards disease-modifying treatment. This is partially pharmacological. Up to 30 drugs are now being tested in trials, but exercise is in fact closest to delivering the promise of becoming a disease-modifying treatment. Another major development is more attention to lifestyle issues. So we talked about exercise, but the next big kid on the block is dietary interventions and handling stress. This circles back to the freezing of gait, because stressful moments can provoke freezing of gait. And there's increasing evidence now that mindfulness and yoga are good treatments. And obviously there will be ongoing developments in the field of stem cells to hopefully restore dopamine producing cells in the brain. This is beautiful work done by Roger Barker in England, and results are expected to arrive soon. Better surgical techniques, including focused ultrasound, I think is an important development. So it is, in the words of the late and great Tom Isaacs, founder of Cure Parkinson's Trust, it's a time of hope. It is a time of hope for people with Parkinson's.
Yeah, it's an exciting to think about how close we may be to some of this hope being actualized. And one of the things I just want to point out as we end here, Bas, that I really align with about the work that you do and even how you go about it. And the thing being that you've mentioned a number of times here about the patients being an active participant in their care, in their diagnoses, in their treatment. And you did, a number of years ago, you did a TED Talk about going from, as a neurologist, from God to guide. And I thought that that was such a meaningful portrayal of keeping the care that we provide as clinicians, as whether industry partners, whatever it might be, around the patients. And as a clinician myself, you know, and being the CEO now of a tech startup that's trying to innovate in care, really focusing on ensuring that the patient is at the root of all that we do as organizations, but also in their own care, in the decisions that are made about their care. And so I just want to point that out, because particularly coming from somebody who's so esteemed and well-established as an expert in the field, and the imaging research and the pharma research and all that you're part of, but it all leads back to the patient. And so I just wanted to call that out and say thank you for the work that you've done, but also keeping focused on that throughout your work.
Well, I should really thank the patients, because they are my muse in many ways. And, you know, it is so gratifying to be able to work with people with Parkinson's. Just today, if I may, I submitted a paper together with a patient, Marina Noordegraaf, who is wonderful and brilliant. She lives with Parkinson's, fascinating, creative brain, and she developed the concept of hopamine. So not restoring dopamine, but restoring dopamine. And she feels that it is crucial that each patient is not just prescribed dopamine, but is supported in finding their own personalized dose of hope.
Mm.
And she has this cartoon of a pillbox containing smileys. And these are little pieces of hope, dopamines. I mean, just brilliant.
That is brilliant. That is brilliant. And what I think a wonderful way to wrap up this conversation, Bas. And I really appreciate you for being here with us today. And more importantly, for the work that you're doing to change the lives of those living with PD and how you're doing it as well. And so thank you for that. And for all those listening, thank you for being with us today. Thanks for watching with us, and keep an eye out for our next episode in May, where our guest is actually going to be one of Bas's colleagues, Dr. Ray Dorsey out of the University of Rochester at the end of May. And as a reminder, if you'd like to watch this episode again, or you'd like to learn more about MedRhythms and what we're doing, our website is www.medrhythms.com. So thank you again, Bas, and thanks all for tuning in.